has been into simulation for many years now. She has trained all across the globe, and she is co-founder of Peristar's simulation group, and she's one of our most experienced faculty. I'm sure you'll learn a lot through the day from her. We are also joined by Dr. Bhavani ma'am. Again, with her vast experience and training from the United Kingdom, she has moved back to India and has worked with multiple hospitals, including KIMS Hospital, Soumya Children's Hospital, and she's an active teacher, trainer, researcher, and speaker. Thank you, ma'am, for joining us. We also have with us Dr. Chetan. Dr. Chetan is a pediatric intensivist who is associated with us at KIMS Secunderabad. Again, he comes with a lot of experience, knowledge in the field of pediatric and neonatal simulation. Thank you so much, Dr. Chetan, for joining us. We shall be joined by Dr. Praveen, who will be joining us at around 8:30. He is consultant neonatologist at Cloudtrain Hospital. And we also have our team of neonatologists from KIMS Cuddles, Dr. Aravinda Lochani. Dr. Gautami is finishing our clinical work, so Dr. Aravinda and Dr. Gautami are important members of our clinical team here at KIMS Kondapur, and I think without their support, we could never have put this workshop together today. We also have Dr. Bhavani and Dr. Sindhu Maru from KIMS Gachibowli. They will also be joining us shortly. So we have a combination of experienced senior faculty members, a few young, dynamic, upcoming consultants who will, I think, give the right recipe for the training for the day. So I heartily thank all the faculty for agreeing to be a part of the simulation workshop today. So without much waste of time, we will begin with the program. I request all of you who have registered to kindly make sure that your nurses and your other friends have already joined you. If not, please text them or maybe call them immediately so that they don't miss out on the workshop. You will be given handouts at the end of the day, so please provide your undivided attention to the sessions, particularly the demonstrations, and do not waste your time in taking notes. A kind request from the faculty members. I'm sure all of you have received this delegate badge. It would be great if you can turn this around and write your name in capital letters in bold on the backside of the delegate ID. If anyone hasn't received your delegate ID, kindly raise your hands so that the organizing team can allot the delegate badge. So on the back side, so you have the front side and the back side. I request you all to kindly write your name in bold letters in the back side. So this will be helpful for the faculty members to address you by name when they begin the workstations. We shall be talking about the allotment of groups after the talks. Each of the groups, that would be 4 groups today, would be identifiable by a certain color. So we have 4 color codes on your ID tags, and we shall be guiding you to the respective stations. The morning stations would all be in the 4th floor. Each of the groups will be accompanied by a volunteer from our team who will be also keeping time and who will be helping you in the rotation from one group to another. We have washrooms opposite the auditorium on the slightly as you turn to the right side, and in case of an emergency or a fire, this is the emergency exit as well. So with these instructions, I think I will welcome Dr. Gitanjali ma'am for the first talk.
Good morning to you all. It's a pleasure to be here in front of the young minds with the shining eyes, and thank you, Aparna and the whole KIMS Cuddles team for organizing this course. So before we start, we want all of you to stand up for a minute, please. Okay, stretch your arms. Up, up. Okay, back, sit down. Right, one more exercise. I want you to close your eyes and think for a minute. What made you smile? What made you smile the last 1 week? And we want to keep these thoughts throughout the day. Alright, so we'll talk about it during the lunch time, what made you smile. Thank you. For the next few minutes, we'll be talking a bit about what is simulation and the introduction to the transport. We will keep all the talks very short, and as promised, we'll make sure that most of it's a hands-on experience, because it's an experiential learning opportunity for all of us, and every time we do, we learn from each other. I want you to look at this picture and tell me what you see. Can you request the ones who are in the back bench to come to the front, please? Otherwise, we'll get more questions. So, more back you are, the more questions to you all. Come to the front. What do you see here? Who's at the most back? What do you see? Come on. Let's have a comment. How many of you are nurses? Can you raise your hand? How many of you nurses? Awesome. So let's have a competition, nurses versus doctors. How many of you are doctors? Okay. So let's see who answers first. What do you see here? Plane crash. Thank you so much. Indeed, it is a plane crash. So this picture is actually very significant, probably one of the world's most important, significant picture. This has changed the way we train across the globe. So this is called a Tenerife crash. This is a KLM and a Pan American. They collided way back in 1977, and lots of people, hundreds and hundreds, died. He was one of the best pilots of the KLM. It was nothing to do with his skills. But there was something else which was responsible for this crash. Sorry, we are trying to put the zoom. Right. Do we need the zoom? Can we remove the zoom? Aparna? Do we need the zoom? Can we just use the top side and put the zoom later? Sorry for the technical glitches. Okay. Sorry about it. So let us just talk through until the slides come. So this was nothing but the human error, right? So how many of you think medical field we are exempted from human error? No? So yes, it happens much more. We'll come to it soon. And now the next question is, how many of you think if you fill in the knowledge and the skills, we can eliminate the errors? Can you raise your hand? Do you want more action? Yes? 1, 2, all right. And so I did not raise my hand because what is missing here is the attitude. So simulation is nothing but knowledge is important, skills is important, but it's the attitude which makes it more holistic approach. So all of you know simulation is nothing but creation of an experience that's similar to the real world, but in a risky environment. It's a culture change. It's making the high risk industries like medical professionals safer. So if you see that the top picture, it's nothing but simulated flight. So after the KLM, the Canary flight, the the flight industry has become much safer. So compared to how many road accidents, every 3 minutes one person dies in India from a road crash. So compared to that, the flight has become much safer. So we all know that whatever I talk now, you remember only 10% of it when you go home. But when we do the practice, that's the simulation, you remember more than 30%. And then we teach others, just like how we did when we become faculty, like the faculty here, we remember much before. So when you find some time, read this book beyond the checklist, how we have implemented the airline industry, the principles into the medical field and help to integrate the simulation. What's happening here? Who's he? What's he doing? Practicing. So is he doing the net practice because he doesn't know how to play cricket? Why is he doing it? Absolutely. So he wants his team to win, right? So imagine this is just for fun. And how many of us practice before we go and treat a sick patient? A septic shock or BPH, how many of us practice? Yeah, something to think about. So this is not told by me or any of the faculty here. Professor Chandler said medicine used to be simple, ineffective and relatively safe, but now it's very complex, effective and potentially dangerous. If you go ask your grandma, they'll tell that they were fine, they just went to their GP or they didn't even have GP, right? But out of 9, 5 of them died or they all survived. But now we are doing more complex things. That means we need to be ready to face things. So what we do with simulation is nothing but experimentation. We are going to do now in a short period. Immerse ourselves in a case. It's unlike the PALS or the NRP training. It's not individual skill training, it's team training. Then you start experience, you start reflecting on it, then you change your mental frame and then go and experiment that on the real patient. It's called the whole learning cycle, maybe one more powerful slide in simulation. So I don't have to tell why simulation. Simulation, we do practice again and again, but no harm to the patient. Unlike what me or Chetan or Dr. Bhavani did when we were students, we saw one, do one, and probably did a lot of harm to the patient before we became expert. All right. So, okay. So what simulation does is bring us from the unconscious incompetence. When I became intern, someone asked me to put a chest in. I said, yeah, I've seen a chest in. I put a chest frame. I thought I knew everything, or I didn't know how to say no, that I'm not expert, and I caused a pneumothorax. But then I realized that I really don't know, I need to learn more. But what simulation does is bring from this unconscious incompetence to unconscious competence phase very quickly. That's because of the practice. So a little bit about the CRM. Ma'am is going to talk about it as well, so I'll go very quickly. So what is crisis? You have a patient, preterm delivery, you bring to the NICU, everybody's running around, putting the lines, and chest X-ray. Is that crisis? No. So a crisis is nothing but a time of difficulty or danger, which involves non-routine circumstances, leading to an increased workload, speed, and complexity. And here you can see this was a neonatal transport in the Scotland. You can see the incubator trying to go inside the helicopter. That was not a crisis for us because we were doing it day in and out. But what was a crisis is the ice on the floor. Every time we tried to put this baby, we were slipping backwards. So we had to step back, make a strategy to get this baby safely without the extubation. Can you think about some of the crises in the neonatal unit? Neonates. We request all of you to put your phone on the silent, please. Thank you. If you haven't done, please take a moment to put your phone on the silent mode. All right. So let's start from here. The first one from the back. Can you think about some neonatal emergencies? Each one, yeah. Neonatal seizures, thank you. The next. You don't have to stand up, you can sit on. It's very informal today and we are going to learn from each other. Yeah. Sudden desaturation, pneumothorax, thanks. Shock, neonatal shock. Obstructed labor, beautiful. Thank you for thinking out of the box. Thank you so much. What are the emergencies you see in neonates? Sorry? Aspiration, yeah. The child comes, gets ventilated, intubated. And now you say you're going home tomorrow and then suddenly child aspirates and back into super action. Retractions. Respiratory failure, absolutely. Thank you so much for that. Birth asphyxia. So everybody's dread, right? Sorry, one behind you. Red dress. Can you think of any neonatal emergencies you've seen? Okay, we'll come. Yeah, of course. Thank you. The neonatal arrest, right? Okay, thank you so much for that. Trauma. So what kind of trauma do you see in neonates? Accident or the fall. So we had seen once a mom happily went to the city center because she was getting bored at home and her dress got caught in the elevator and the 9-month-old child fell and then child was dead. So brought immediately to the hospital, but we couldn't do anything. So fall can happen in the babies or iatrogenic also. Any other neonatal emergencies you've seen? So getting more tougher to this side now. We have to say what they haven't said. Hypoglycemia, awesome. Thank you so much. Again, thinking out of the box. Yeah, the last benches. Hypothermia, wonderful. Most important in neonates and simple also. If we take care of hypothermia, I think half the war is won. Hypothermia also, the temperature, or maybe cooking the child, like how I feel I'm getting cooked now. That's because, not because of the room. Aparna has kept a beautiful room. It's because of me. Okay, any other? Preterm delivery. Can you think about something more related to the preterm? How about triplets? Right, the triplets, conjoined twins, or something with the abnormal heart, abnormal lung, abnormal brain, all these are neonatal emergencies. So we are not going to go into detail about it because we are going to do that in the afternoon. We want you to just think how as a team we can manage. So what you all said, there are certain things we cannot change, right? But factors associated with crisis, that is a NTS, is a term we borrowed from the airline industry, non-technical skills. So what we can do better is utilizing these NTS, the principles for a better outcome. That's why we are all here. For example, patient issues, right? Preterm delivery, probably we can't do much, but with the effective leadership and role clarity, knowing who has to do what, preparedness, we can make a better outcome for that baby. Disease process, PPHN, again, we probably can't do much. Maybe we can, but that takes time. But with the effective communication and the cross-check technique, we can make a better outcome for this child, especially if it's a transport, right? Circumstances of the crisis situation, right? For example, someone said hypocalcemia or hypothermia, probably we can't do too much. But if we use all these NTS, the leadership, communication, situation awareness, effective utilization of the resources. Can you give an example for effective utilization of resources? Yes, absolutely. So you go there, the term baby, you said the birth asphyxia, you try to intubate and suddenly you feel there's nothing, you can't see. Yeah, the ENT may be sitting there having coffee. So if you haven't realized, if you keep intubating, haven't called them, then we're going to lose a battle, right? So immediately call them and say, so it may not be you, it's just the baby. So just one simple example. Or you can call the anesthetists who are next door doing the LSCS, right? Ongoing global assessment and feedback. Can you give an example for the global assessment? Again, having a leader. Most of the time we see the leader
bending backwards and then intubating, right? So it's good for the leader to step back at the foot end. Look at all this after, this is from Professor Gaba from Stanford, again, one of the key person who's brought the simulation from the airline industry, the medical field. So look at all these principles he's told us. This is a busy slide. Think about an emergency where you call for help early or you did not call for help early. These are all the NTS factors, right? It's not knowing how to intubate, or it's not knowing how to put an IV line or a central line in a child. This is about the human factors. I wanted to think about a situation where you did well or you did not well. Again, we'll discuss during the break. Call for help early, anticipate and plan. For example, twin delivery. Know the environment, however good you are, you go to a new place and suddenly you get a code blue and you end up going to the adult side than the pediatric side, right? Know the environment and you get lost there if you don't know where the crash part is. Use all the available information. A mother may be saying, my child hasn't been fed, and you're going on giving antibiotic when the child is fitting. It may be simple hypoglycemia. Allocate attention wisely, mobilize the resources where you did mobilize or you did not mobilize. Cognitive aids. What do you mean by cognitive aid? What is the saturation of a term baby at 2 minutes? Normal saturation. What is it at 5 minutes? I can't remember. It's very hard, right? So cognitive aid means you have that in your delivery suite. So you can look at it and see, this is okay, or this is abnormal. I got to do something, right? The same for the algorithm for seizures. Communicate effectively, distribute the workload. There may be some junior nurse sitting there and doing nothing. She may be brilliant in talking to the family or very good in putting the cannula. We are not using, we are just telling the in-charge, sister put the oxygen, sister put the, give the antibiotic, suction bhi karo, aur ek antibiotic leke aao, aur thoda fluid de do, right? So effective distribution of the workload, establish role clarity. Who's doing what? If everybody is doing cannula, then you're not going to have, or sometimes you want to intubate, you say sister tube and everybody goes out. No one is there at the bedside. Has it happened to you? Yeah, has it happened to anybody? So we have to make sure role clarity. Or if you say, Sister Vinita, can you go get me 3.5 ET2, one size less, one size bigger, then it will be role clarity. Or can you look after the fluids? You don't worry about the ET2 and the leadership. So think about a situation. You can close your eyes for a minute. Think about a situation where you did well and you did not do well. So you have 1 minute and we'll talk about it soon. How much time we have? Okay. All right. So fast forward 1 minute. So I wanted to practice this in the afternoon, closed loop communication. So both by the leader, team lead, we will be having this team lead role allocation, the team member. So give a request, it's not order, request. Listen for the verbal confirmation. I am giving 10 ml of 10% glucose. And then avoid confirmation task is completed. I have given adrenaline, right? And then, can you tell that when you have given it, team member confirm the request is heard. Yes, I'm going to get a size 3 ET tube. Inform the team leader when the task begins and verifies the order. So we wanted to do this. So just go to some of the where simulation can be used. Skill training, you can see here at the bottom, WAP training and the top UVC. And then the intubation, or it can be CPR or temperature maintenance. Some of you said it's very important. So it's a hybrid simulation. Mother as one of the actors and then baby as a mannequin. Or in the sim lab, some of you may have seen it, or if you haven't, visit a sim lab nearby and see how they're doing the mock codes. And then these are some of the immersive simulations which we'll be doing throughout the day, preterm delivery or the transport or abruptio placenta or multiple births. Or the neonatal resuscitation. I'll skip this slide. Again, it can be in situ. You don't have to have a sim lab. or in the sim center. So I'll skip the zones again. So now the neonatal transport we'll be doing this afternoon. How many of you done transport? Can you raise your hand? Beautiful, beautiful. Thank you so much. So how many of you done in the ground transport? How many of you done within the hospital? Can you raise your hand? Intubated baby within the hospital? Awesome. That is a second picture where the ECMO child going into the CT scan. It's not a real child, but it's a simulation. We want to make sure that the team knows how to get the baby in and out without cannula coming off. And then, of course, air transport. Now we have a task. You get a call from Kukatpalli. You are in Kondapur now, and there is a baby, meconium aspiration, PPHN, and they have intubated. You are asked to retrieve to Kondapur, right? Okay, simple. Yeah, PPHN, term baby, and they are stabilizing the child. That is a Kukatpalli. They're putting the ETG. So I want you to think about everything you need to safely get that baby from Kukatpalli to the Kondapur. Okay, think about the equipment, think about the personnel, communication and medication. All the equipments do you have a pen and paper? Yeah, we want you to write down. And the team there also, write down everything you need to get this baby safely. All the equipment you need, who all you need, personnel, who do you have to communicate? Think about the communication within the team, within the hospital, referral hospital, and the ambulance team, and which medications you need to keep ready, including the fluids, to get this baby safe. And the communication also to the local team, the Kukatpalli team, what they need to do before you go there. So we need the team on my right side, top more, and then the team to the left side. 1 more minute. Okay. Right. So team from the to my right, the last benches. So can you talk about something about the equipment? What equipment do we need? We can talk to each other. Yeah, you can talk to the person next to you. Here also, person next to you, and you can compare your list and add to it. All right, the last two, you can stand up, both of you. What equipment do we need? Ambu bag, thank you. Sorry. Laryngoscope and blade, intubation, airway equipments. Okay, always go with the ABC. Thank you so much. Next. All of you can join in. Yeah, what equipment do you need? Mass, okay, beautiful. Airway. Think about everything. Do we need an incubator? Do you need ambulance? Okay, each one, can you talk about few things you need in the equipment? Transport ventilator. Okay, next, who wants to add to it? Anything? ET2. Beautiful, thank you. Okay, team here, the personnel. Who all do you need to go get this child safely? Can you just jump in the ambulance with the ambulance driver? Who do you need? Doctor? Who else? Most important person. Nurse. The nurse who knows what to do. Thank you for that. Who else do you need? You need to inform your attendee, right? Or if it's a surgical child, inform the surgeon, inform the neurosurgeon or general surgeon. And the communication, who do you have to communicate? Okay, do you want to help them? Who do you have to communicate? Local team, so you need to tell them, don't just intubate, get a UVC in or get 2 IV cannulas. We will come and put the UVC and inform the family, right? Communication, get a consent from the family. And what else you need to communicate? Who else? Ambulance driver, ambulance team, who else you need to communicate? Local hospital, yeah, alternate number. They may be calling you, suddenly the phone gets cut off, so you're lost. So our responsibility starts the minute we pick up the phone, we are responsible for that child, right? Not after we go there. So think about that, and then we will rehearse in the afternoon whom all we have to communicate. What medication we need? Yeah, you can stand up and say, what things we need to keep ready? What all can happen to this child? Yeah, you can stand up and say. Okay, do you want to help? Adrenaline? Vitamin K, beautiful. 10%. What can happen to your PPHN child? What about fluids? Normal saline. Okay. What we will do is we'll end it just to give you a flavor. I just want to add, the aviation has done something about it, the human errors, the simulation with dramatic results. Flying is incredibly safe now. The lessons are clear, the cause is urgent, and the time has come for all of us to embrace the simulation because it's time to act. And I will hand over this to Dr. Bhavani, madam. If any question, we can discuss during the tea time. Okay. Thank you so much for being such interactive participant, and keep it up throughout the day. Thank you. Good morning. Okay. I think my talk or my discussion that is not a station or can you hear me from the mic? Yeah. So why something very, very important. Okay. Why is more going to be on systematic approach? Right. Okay. It's going to be on the right management. Yes, what of how well we can do it? How can we do this in a systematic way? Okay. So before everything, I want you to watch this video and comment. So I hope this works. How many of you know Mr. Bean? Yeah, we all like Mr. Bean. At least I love Mr. Bean. Can I use my, okay. Of course, this is YouTube, so we'll get some ads, unfortunately. Skip ads. Okay, 1 second. No, I don't want everything. It's a 12-minute video. What I'm going to do is fast forward it to where I want. Yeah. Can you all see? Isn't it? Yeah. Will stop. Oh, I want to stop here. Back to the presentation. I want you to tell me what's happening there. What happened? Go here. And then it is going to do some beyond. And then he takes something beyond. Okay, and you also need some ground. Okay, so there. Then what was the language? No, thank you. He is not a trained man, so he was not doing it in the right way. Okay, so ultimately, though he survived because of his lack of coordination and lack of awareness, the man collapsed again. Okay, so this is to say, if you do not have a systematic approach, the outcomes are going to be bad. Okay, so let us see what is meant by a systematic approach. Okay, what is a systematic approach? Let us understand why is it important, and we'll have some evidence to it. And how can we make it possible in our scenario, okay, in our own hospitals, and we'll go with some real life examples again. So what is a systematic approach? Systematic approach is nothing but it is just, it is a structured way of doing things. Okay, a very structured way of doing things. See, healthcare is a very complex process, especially dealing with an emergency is a very, very complex process. So it is the way how we break it into simple processes, okay, and then learn it and then do it, okay. So it is a predefined sequence or methodology, and I think Dr. Gitanjali has stressed enough about the core of systematic approach is communication. Communication, communication, and communication. So we need to have an effective communication for the systematic approach to work. Why is it important? I think each one of you can tell. Already it is there. Okay. We need. Why is systematic approach important? Better outcomes. You need to prioritize your tasks. You need to get things, the assessment should be accurate. You need to gather information systematically, isn't it? Teamwork is important, right? So all these are important, and most importantly to me, communication and documentation are the most important things. Documentation, unless you document it, you cannot actually see, you are not going to be there for 24 hours of the day or 24/7, isn't it? There is somebody else who is going to take over. How will that person know what you have done? You need to have that kind of a continuation, and documentation is the only way that can help you. Documentation either in the form of your handwritten notes or an electronic record, or, even a video recording, right? So some evidences to show that systematic approach really works. There is, in China, they have done that weekly training of the staff dealing with emergencies have actually improved the neonatal outcomes. How often do we do that? Yeah, a systematic approach. How many times have we been really trained and retrained? Trained maybe once, but we really forget. Go back and never think about it again. So this is the most important thing. So thinking about our emergencies and then having a process in place that we actually get retraining all the time or refreshing our systems. Again, there is another evidence to say that teamwork and adherence to guidelines on newborn resuscitation. Actually, what they have done is a video recording of an emergency and then went back and try. So we don't have weekly training, but we do have emergencies, right?
So we can make these real life into a training scenario. So maybe there is you can have a video recording of an emergency situation. You have newborns in the theater, you have newborns in the normal the delivery ward. Okay, now you put a camera, maybe CC camera, and record of how it is being done. Now you go back and take that video and see how it can be done differently. That can be used as a training video. That's what they have done. And then Dr. Gitanjali was saying non-technical skills. So the people who had non-technical skills did better. So those who have better communication, better documentation, better teamwork skills, they did better than just with the technical skills. So I know how to intubate, but I don't know how to communicate. Then the outcome is going to be bad, right? Again, I think lots of evidences. We don't need to go into these evidences. My talk is really going to be short. Now, I think we had talked enough in Dr. Gitanjali's talk, but give me 2 examples outside healthcare industry where systematic approach is taken, a systematized approach. Some examples? Where, sorry? Airline industry, very good. Airline industry is where we had learned a lot of lessons from. Okay? You take any process in the airline industry, not just airline industry, even when we go into the airport, the way you check in, the way you do a security check-in, the way you board into a plane, everything is systematic. There is no way of going that way or this way. How is it that done? That is done by repeated training, that's all. They have, everybody has got their set of responsibilities and they do their job. And you see that cockpit, this cockpit, they have, oh, this is not in a, I didn't realize that. How do I make it into a screen? Just, no. No. Full screen. Okay. So how do you think? See, they are so experienced. These people are, they would have done hundreds and thousands of flights. But what do they do every time? What do they do every time? They have a checklist in front of them. Every time they have to take off or every time they land, they look at the checklist. Not that they don't know. Not that they have no experience at all. Even the most experienced one will look at the checklist and then they do everything accordingly. And they tell each other what they are doing. That is what is communication. Okay. So that is how it works and that is how nearly 100% safety is achieved. And that is what is needed for us as well, as because we are dealing with lives directly, isn't it? So we need to be really trained to deal with the lives. Okay, so that is the importance. That is what we need to learn. Next is automobile industry. Very safe, isn't it? Cars are really nearly safe. Okay, I mean, of course, there are lots of other factors, but cars per se, and then the way they are manufactured. Suppose, I think this is the Toyota industry, and Toyota has actually changed the way things are looked at in terms of quality and everything. Okay, so the way they do, suppose if they had done haphazardly, before fixing the doors, before fixing the interiors, they fix the doors. Or before fixing the interiors, they did the outside body. Suppose, you know, if they did in a haphazard manner, what would happen? The car will not come out in the required shape, right? So they have automated everything in such a way that you get a neat car out. Okay, so that is how we need to be when we want our babies to come out of our emergencies, right? Now, coming back to the neonatal emergencies, how can we do this systematically? What is a systematic approach in neonatal emergencies? Taking lessons from everybody. What is a systematic approach? What do we do? A, B, C. Neonates before A. So we know it. There is nothing new to say. Okay. I'm not going to do this. We are going to actually practice this. It is T, A, B, C, D, E. D is drugs, E is exposure or evaluation for me at the end. Don't go for, oh, what is wrong with this baby first. But first do whatever is needed and then think of what to do next. Okay, so evaluation comes at the last. Now, how can we achieve this kind of a systematic approach in neonatal emergencies? How can we do this? Examples. How can we do? How can we achieve this? Okay. Number one, teamwork. We need to have a team. Okay. Assign roles and responsibilities to each of the team members. Training, repeated mock drills. Okay. And then a lot of improvement needs to be done. Okay. So whenever you talk to me, everything comes back to QI for me. Okay, because I'm interested in QI, everything comes back to QI. There is so much that we can do with QI, quality improvement. Okay, so we can have, yes, we know what to do, but we are not able to achieve this. So let us start some QI initiatives. Let us start some mock drills and then get this done. Okay, so that is what we are going to do this afternoon, isn't it? So just some feed for thought. What type of QI initiatives that you can do? Maybe, you know, you need for any QI initiative, you need metrics to monitor and you need some change ideas. Examples, you can have your own change ideas, your own everything. You know, for example, you can monitor number of emergencies attended in a month and a number of emergencies where documentation was appropriate. All these are easy to monitor, isn't it? You don't need any extra resources, right? You just need to monitor them. And when doing NRP, number of babies where positive pressure was given within 1 minute. Is that what we need to do? Yeah, less than 1 minute, golden minute, you need to initiate positive pressure if needed. And then where temperature was within normal limits. Percentage of babies where saturation probe was used appropriately. Because this is a part of NRP right now, isn't it? To use the saturation probe. And percentage of resuscitation where a debrief was done after that. See, these are all some things that you can have and, improve your own processes. This helps in a lot of the systematic approach. Okay. And this is my last slide and I'm going to leave you with this video again. Where everything is done systematically and whether you can skip it, video will play after the ad. I'll fast forward. So this is the real life. Somebody came in with the road traffic accident with a lot of loss of lives. what they're saying is there is one communications person there. Okay, in that team, there is a communications person who will actually communicate with the patient and with the team and the outside people. And there is separate person who will put all the lines. So there is a respiratory therapist. And that person, that Gandhi or whoever person in the vault is the leader of the team. He is not doing anything, but he is overseeing everything. He is the person. So again, I'll stop here. Within 7 minutes of coming into the emergency room, they realized that this patient needs to go to the operating theater. And there was somebody coordinating everything. The leader has done it. How was this possible? And 9 minutes, he was in the theater. Okay. So don't think that this can happen in a country, where everything is there. Yeah. So don't think that this can happen only there. This can happen even here. It only needs our change in attitude. Okay. It only needs, a teamwork and just what we need to do really. Understand what we are doing. Where is my presentation? Neonatal emergencies. Okay. Anyway, I think this is with the Zoom, it's become very complicated. Yeah. Anyway, so think about your thinking during emergencies is what I would like to stop and say. Okay. So we need to understand that we need a change in attitude. That's all. Okay. So that is what we are going to learn. The teamwork, communication, and documentation. Thank you.
Thank you, ma'am. So we have kind of listened to two very important lectures, which have oriented us to the concept of crisis resource management and an approach to neonatal transport. And Bhavani ma'am has spoken to you about think about how you're going to manage emergencies more effectively and the importance of being prepared as a team. So I know that some of the delegates have been joining us during the talks. So I once again extend a warm welcome to all the delegates who were not there during our initial introduction. It is also my pleasure to introduce some faculty who weren't there in our initial round of introduction. Maybe Dr. Praveen can just wave a hi to everyone. Dr. Praveen is consultant neonatologist at Cloud9 Hospital, and he's a NEST trained simulation trainer, and he's done his DNB training in neonatology in Hyderabad, and he's a great clinician, a speaker, and a teacher as well. Thank you, Dr. Praveen, for being a part of the workshop. Dr. Bhavani and Dr. Sindhu have also joined us. Dr. Bhavani, if you could just get up. She's done her DM in neonatology from Chennai, and she is working now as consultant neonatologist at KIMS Kachipoli. And Dr. Sindhu also was with us. I think she has gone down to get her station ready. You have all met, I think, Dr. Aravinda. Dr. Gautami was here a while ago. I think she has also gone down for preparing for the simulation. So now we start the exciting part, the workstations. So first, before we go on to the group division, can we just have kind of hands up for all the nurses who have joined us today? All nurses, can you just put your hands up? Great. Thank Thank you all. So that's a good number. So can you all tell where all you are from, this group? Secunderabad KIMS. So you are with Dr. Chetan. How many of you have come? 3 of you. Okay. I saw some groups there. So I know 4 of you in the last bench are from KIMS Kondapur. Okay. This group, you are from Neonatal. How many of you from Neonatal? 2 members. Dr. Swapna must have sent you. Right. Thank you. And the other group, Sri Krishna Hospital, Warangal. Great. All the way from Warangal. 2 members. Great, sister. Thank you. I hope your travel and all was comfortable. You will be going back today, right? You are there for a conference or no, you're going back today. Anybody else? Any other group we have missed? Prashanti Hospital, Warangal. I think 2 of you. 2. Great. I think we have seen all the nurses. Have I missed anybody? Right. So all the doctors, can you now put up your hands? Right. Thank you. So how many of you are practicing doctors or post-graduation? Okay, right. Okay, so I believe then most of you are doing your MD pediatrics or DNP, DPNP pediatrics, right? So any of you from outside Hyderabad? 3, 4 of you. So you are all from Prashanti Hospital, Warangal. And yourself? You're from Gulbarga, right? Okay. You are working as a PG or where? ESIC in Gulbarga. Great. Thank you. Please sit down. Okay. And yes, both of you? Okay. You're doing your MD or you're doing your MD pediatrics? Okay. Yeah, I know some of you here familiar faces. So we have 4 of our fellows, I think PICU 2 fellows, and any of our DNP pediatric students here, 2 of you. Any other DNP pediatric PGs? You are from? Sorry? Registrar. Where? Okay, in PICU. And yourself? You are working at training center. Okay, great. So now I presume all of you have received a delegate ID card. If any of you hasn't received yet, please raise your hands and let us know. Has everyone received one? Yes. Anyone who hasn't received the delegate card? Right. So now to make things easy, we have color coded these delegate cards. There must be 4 colors. So there is red, blue, yellow, and green, right? So those of you who are red are group A. So all reds, can you please raise your hands up again? Those of you who are not the red tag, I hope the tag, this tag and these are same color. Okay. So all of you are going to be group A, right? So red's group A. And Kiran is going to be your coordinator. He'll be kind of taking you through the stations. Group B is blue, B for B. All of you who are blue, you're group B, right? So Kamal is going to coordinate. Kamal, can you just say? Yeah. So he's Kamal. Kamal is going to be taking you through all the stations. Group C is yellow. All yellows, right? So you are all in group C and Vasu. So he's Vasu. Vasu will be guiding you through the stations and will be keeping time. Group D, green. Right. So those of you who are green, you're group D. Shrikant, Mr. Shrikant, the tallest man here, he is going to be your coordinator. So he'll be taking you through the stations. So I'll just tell where we are going to begin the first station, and from there, the rotation sequence they all know. So group A is going to begin with the Cuddles OT, and we'll be beginning with a resuscitation scenario. So Kiran will be taking group A to OT. Group B will be taken by Kamal to the NICU 2. The NICU on the right side as you enter from the 4th floor. Group C will accompany Vasu, and you will all go to NICU 1, the NICU bay on your left as you enter. And group D will accompany Mr. Shrikant, and you will all go to one of the rooms in the 4th floor, 422. That will be your first station. From there, the team will be rotating you to the station. So you all must be clear. The rotation is going to be clockwise. So group 1 will go to 2, 2 to 3, 3 to 4, 4 to 1, and vice versa.
So each group is going to be for each station is going to be for 40 minutes. So all of you have a bell with you, and please ring the bell once at 10 minutes before the finishing time. Actually, it's 45 minutes, and one more at 5 minutes where we will just wind up because we need 5 minutes for the rotation itself. So after these 4 rotations, we will be assembling back to the auditorium, and we'll have lunch followed by the afternoon workstations. So I think that's it from my end. Anyone has any questions? So one of the rotations will be recorded. So I kindly request the faculty to bear with the slight inconvenience. So for the sake of relaying it on the YouTube live, each of the stations, one time it will be kind of recorded live on the sort of through the phone camera, and that will be going on live. So we are live on YouTube today for the whole day. So if there are no questions, I think we shall just break for the stations. So please accompany your respective guides for the groups.
On the next 45 minutes or 40 minutes only, what we are going to do is we'll enact a scenario. So you will get a monitor, you will really see what's happening. Who's going to go first? First team? Okay, you're going to go as a team. And so this is a baby whose mother had no antenatal checkups. Okay, rushed to the KIMS hospital here and had undergone an emergency section or an urgent section for a cord collapse. Okay, you are asked to do things. So don't tell me, but do and talk while you're doing it. What you're doing. That is what is communication. Okay.
Just prior to that one, like our implements will get earlier. So like take care of my equipment for airway corner and go back everything and like like is there any respect with this?
Risk factors? What do you mean by risk
Like
factors?
gestation age, what is the gestation age?
It's a term baby.
Amniotic baby is there, Holzman vector is there.
No foul smelling like that, but it is a meconium stain like.
Other risk factors like infant pregnancies.
It's a singleton pregnancy.
Like umbilical cord management, anything.
Yeah, umbilical cord.
Yeah, I'm checking like temperature count. Warmer is getting ready, keeping on. Kept on manual mode. On temperature is 100% validity.
The other thing is here, right? It's the other 4 members. I want you to observe and then comment after this. Please go.
First temperature part I'm taking care of. Can take care of like airway part. Then that's like other blood spot sister can take this take blood list if it is there or not can come up here. Then my temperature like warmer is keeping on and keeping on servo mode and keeping temperature 100%. And so lineage class warm lineage class must take temporary temperature is kept here. Then checking for airway part is like ammo bag is there. Proper size mark. That's what two days.
Comment later. Okay. Let's end it. This is what I mean.
Then blood spot is very nice and take 100% everyday and you can take into 100 seconds and after that 82 3 and 3.5 size is there on and blood spot you can take. Drugs like 10% export, 10 minutes, and I think what is there, and vitamin D, keep it running. Suction tube. Suction tube system. Equipments are ready.
So your baby is here right now. I think what is it, sister? Baby cries is 9:28.
Yeah, what is the time of delivery? Baby is okay. Baby cried or not?
No, baby did not cry.
Initially, it's not some control like some temperature probe. On monitor also you can connect. Stimulation initially we did on one. Check for this heart rate on and move back. And is that right?
No, the baby is not crying.
On giving positive pressure ventilation. Pulse oximeter can chest rise is not there, adjusting.
Any?
Try is heart
No
rate.
crying, no crying.
Heart rate. Heart rate is one more cycle faster. Test price is there.
Test price is there, yes.
One more cycle. If the heart rate is more than 100,
That's the real heart rate.
then plan to intubate. Test price is there. Get laryngeal scope with EKG, 2.5, 3 like. So the chest size is there. Just check on. After take one. After take step. Take step. And is their heart rate is more than 100? Heart rate is more than 100.
That's the real heart rate.
Let's start CPR. Just start CPR. 1, 2, 3, breathe. 1, 2, 3. You need to shout 1, 2, 3. Sound system. 1, 2, 3. Breathe. 1, 3. Breathe. 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 Just a manual secure IV cannula. Breathe. 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 Just take other. Breathe. Liquid cannula. Weight man approximately taking as 3 kilos. So that is diluted 1 in 9 ml. Take in 1 ml syringe. 0.6 ml in it. Breathe. 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 Give adrenaline sister. Give adrenaline. 1, 2, 3. Breathe. 1, 2, 3. Breathe. 1, 2, 3. Breathe. 1, 2, 3. Breathe. Breathe. Go fast. Breathe. 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 Give. Breathe. Line secured. Now line secured. You can give on the. Breathe. 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 I mean, was secured canvas. Secured. You need to tell whether secured or not. Breathe. 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 Breathe.
Breathe. Breathe. Breathe. Breathe. Breathe. Breathe. Breathe. And give adrenaline through IV vein. Breathe. Okay. Breathe. 0.6 ml give system. Again, breathe. 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 Again, give us. Breathe it healthy. Breathe. 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 Good.
I think we should stop here. Good. Well done. Okay. Now I want you to tell the real positive things about this team and how they have done. I don't want any negative things now. Telling what are the parts. Aim correct ga chesaru vallu. Correct ga em chesaru. Very good. They were communicating well within the team. Well, inka next chala positives unnai. I tell at least 5 or 6. Tell me one more. One positive thing. Coordination, communication. Okay. They have followed steps in sequence. I will come back to that later. Next. Compression and breaths, they have done well. Okay. 1, 2, 3, breathe. 1, 2, 3, breathe. They have done well. Okay. What else did they do well? PPV was initiated within the first minute. Right? So golden minute was followed. Very good. What else? What else did they do well? There was a leader who was directing, right? He was telling what to do to others. So there is an effective leader who is communicating with his team. Okay. So well done. And the best outcome is the baby survived. The baby's heart rate improved to 90 and the saturations improved to 90 after what they have done. Okay. Right. Now, what could be improved and other positive things? They did check the equipment before they came. He switched on the warmer. He did ask all the right questions. Before starting the NRP, he did ask all the right questions. Did he or not? Term baby or not? Meconium etla undi ani adigaru. Dan tarvata singleton and cord management also he asked. Right? So they did very well. Now, what could be better? If suppose you were there in this situation, what would you have done? Em cheste bagunde. Okay.
Can answer again.
అని చెప్పాల్సింది చెప్పగానే yes done అని చెప్పాలి తెలియదు లేకపోతే how many times given అనేది కూడా మనకు తెలియదు. Okay, right. Next. Okay, what could have been improved? Go from the beginning. Absolutely. See, there is no washing hands and gloves are here. Gloves వేసుకోలేదు. Number 1. Next. Very good. Yeah, okay. So they did not remove the wet linen. There is a fresh linen here already. Who checked that it was there, but this was not done. Okay. What else? Next step. Equipment checkup. What you have to do is go according to ABC. Don't randomly do things. Okay. Don't randomly do things. Airway equipment, breathing ki kavalsinavi, then circulation ki kavalsinavi. Anni unnaya leda chusukovali in an order so that you are not missing anything. This is what is the training for. Isn't it? This is what is the training for. That is what happens. See, what you have done is real emergency. Baby has not cried. You know this baby is going to have HIV. So you want to prevent that. So this is the stress that you have inside you when you have a real baby and then you forget things. But you do this repeatedly, you will understand. Right? So go according to A, B, C, D. A unnai, A kavali. Anni unnaya leda work chestunnaya. Right? Next. Equipment check happen. Baby ochindi. What should have happened? So that all you did very well. The assessment was good. And the other thing what he did was he noticed that there was not a chest rise, and then he did shout saying repositioning and doing bag and mask. Okay. Now with the bag and mask. Okay. When you see a neopa, please use a neopa. Okay, this is much better than if this is not there. Okay, please use neopa. And there is a blender. You need to use, this is a term baby. What do you use? Air. 21% oxygen you need to use. Right? Next. Assessment law. You did the airway assessment right. What is the immediate next step? You need to look at the heart rate. Yeah, step. Step epudu chesaru? CPR time low. So you did not assess the heart rate. And the heart rate was going 30, 30, 30 for a long time. I gave you a clue that it is 30. When do you start CPR? Less than 60. The idea of putting 60 is, 30 is that you should have started CPR as soon as you started the positive pressure. You know, you listen to the heart rate. The heart rate is 30. So you should have started the CPR immediately. When did you start? After intubation, you start. Correct. I agree. But I think yeah, I completely agree with you. There was no change in heart rate, but you should have assessed frequently. This is, somebody will do this. Don't do all those things. Okay. Now that is done. Compression, 100% oxygen. ECG leads andarki untai undakapovachu, but ideally ECG leads unte you have to connect. That is according to the protocol now, isn't it? Okay. But ikkada levu kabatti let us say yes, that they're not there. Right. What? Before 60, again yeah. Before, yeah, even before Aravinda, what I would say here is, what is the easiest way of IV access in an emergency? Okay. Don't go for IV cannula. This is you're wasting your time here. IV, securing an IV cannula in an emergency situation is really, really going to be bad. Okay. So what I would do at that time is, as a leader, probably if you have confidence in your team that somebody would be able to do this, yes, you continue to do this. But otherwise, you have secured an ET tube, you are doing a positive pressure, you ask, you come and take care of the airway. I will now do the UVC. Now, if necessary, you have decided that you are going to go towards using drugs. If necessary, you have to call for someone else. You might need help now, isn't it? Mugure unnaru, ikkada don't count her. Okay, don't count her. Okay, muguru unnaru, inkokadu kavalante meer immediate ga phone chesi pilavali. So you had done the ET tube. See, that was a quick thinking. IV cannula ledu anagane you did a ET tube because you wanted to give something. Right. And then what should happen after this? Yes, baby survived. What will happen after? Important thing. Council? Important aspect. Exactly. I would say leader, as a doctor taking care of the baby, you tell them, instruct them, you continue with your positive pressure ventilation, you have stopped, keep monitoring the child, I will go talk to the parents and come. Understood? Yeah. Anything else? Anybody wants to? Yeah. Second dose. Well done. You can give. ET is not counted. ET is not counted. You thought on your feet, that is good. ET is not counted. So, yeah.
Like heart rate below 100 also stable, man. After
60 to 200. More than 60 only, you stop your CPR. Don't continue. Okay. I think you continue. You continued even after almost 90 you will continue. You should keep looking at the monitor. This is a real life scenario. There is a monitor there, isn't it? Heart rate is changing. Your saturations are changing. That is what we want. This is not just any other workstation where the instructor is actually telling you what to do. Aravinda? Good. Well done. I think. Any doubts? So what do you think? You need more practice. You keep doing this. You will understand. It doesn't take much time. Weekly one chesaru, manam kanisam nelakosarana cheskunte itlanti scenarios. It doesn't take much time, isn't it? You just come here with a team and then start that. Okay? What will help is don't remember anything. I will say don't remember anything. Put a big poster of resuscitation, NRP. NRP అది స్టిక్ పెద్ద చేసుకొని గోల్డ్ లెటర్స్ లో కలర్ఫుల్ గా పెట్టుకుంటే you see that and do. Nobody is asking you to remember. Please don't remember anything. Okay? The only thing is you have to remember the adrenaline dose. You don't need to wait. Don't wait. Please. Yeah. So okay. Right. Now we have time for another scenario. Okay. Swap. Please say my name. Only baby. Scenario. Okay. Now again we have a 30-weeker mother, 30-week gestation mother who has come. Okay. The mother had regular antenatal checkups now in the same hospital here. Okay. But she came for an antenatal checkup today and she started bleeding. Okay. So after assessing her, they had to take her for an emergency section because it was an abruption. 30-weeker abruption. Records. Can you get it?
No, 5 minutes more.
5 minutes. Yeah. I have to walk. Okay. You haven't used Neonatal before. No. Okay. You have used neopuff before? No? Neopuff. Until leg asal. Please go and check. You come here. Very good. Okay. You wash your hands. Yeah, the other thing what they have done well is they're putting the manual mode and put it to 100% off. Yeah, very good. What is the pressure you are doing, sister?
I'm checking, keeping
20. Okay, go ahead. 20 over
60.
Okay, what else you want to check?
Plastic wrap. Yeah, it's good. 2.5.
Okay.
Plastic wrap.
Good. Your baby is there.
The surgical you have to do.
Yeah, imagine they are surgical gloves. Plastic is. You can ask.
KIMS.
No, baby is not crying.
Baby having breathing.
No breathing.
Now we have to remove the spectrum.
There is no chest rise.
The position. Get the suction ready.
Baby is not having any breathing.
Application position. If the 10 meters slope, then it's the option. 10 meters slope.
Maybe you have not connected the SpO2 properly. Baby started breathing now. Okay, I think there may be a problem in the saturation flow, but the saturations are probably around 60. Baby started breathing. Okay. Okay.
Ma'am, baby's efforts are good.
Baby's efforts are good.
And
Yes, baby is having. Okay. Right, we'll stop it here. Good, well done. Yes. What did you do then?
Full allocation.
Okay.
Then we need to on the cost of development. Then repositioning.
So repositioning successfully when there was no chest rise, they have done that. Okay. And it was an appropriate pressure. Okay. Of course, I gave you the answer at the beginning that it was a preterm baby. But what are you? Yeah. Okay. Right. What could they have done better? Yeah. Okay. There was correct. No, I said that yes, you have washed your hands because they wanted to say they said they want to wash hands and come. I said you wash your hands now. That's because of lack of time. Okay, lack of time. Very good. Yeah. Okay, I think that is important. Okay, very good. Inka?
mask should be. People should check on the face.
We should have used a preterm mask. Okay. What else? Okay. Again, use your stethoscope and listen to the heart rate. Don't rely on it. I didn't see that. After 1 minute, Tony, I think we should get used to listening to the heart rate. And for a long time, you didn't connect the saturation probe. Saturation probe connect chestane. Okay. So you were trying to look at the monitor, but there is nothing because there was no saturation there. So what was the percentage of oxygen you would have used? You were using only oxygen there. It's a preterm, 30 liter. What would you have used? 21 to 30%. When I said after a few cycles, I said there was no response. Baby still not breathing, not efforts. You could have increased the oxygen to 30%. Right? So these things will come only with practice. Right? Anything else? And I think putting the paper, the plastic sheet on, when do you put it? Receiving the baby. You should actually ideally open that mundar nunchi open chesi pettukoni, you have to put baby under the paper. Don't dry the baby when you put plastic sheet. You took out the material that you put, but you should have inserted the baby under the paper. Not after the baby comes trying to lift the baby and put. Anything that you want to ask? Any questions?
Up to like one cycle only, we can take.
Correct. If, see, in between, what I would say is, time has been passing. Time out there only. So keep a watch on always you should have an eye on the clock as well, how many minutes have passed. Without knowing, everything will go like that. So every minute after every cycle of your giving a positive pressure, but still there are no ECG leads. ECG leads okay, you don't need to listen to the heart rate so much, but keep using your stethoscope, put it under in your neck itself. Keep listening. Keep listening. ఇక్కడ heart rate is there because monitor లో ఉంది కాబట్టి వస్తోంది. So we are relying on that, but you have to have your setup. Aravinda? Okay, right? So please go back and
That is the last part, as I said. HFO mode. HFO has to be converted. Why don't you such a FIO when the baby is such a so it has to be changed to a PIP. PIP has to be changed based on chest size of it. How much chest size you want based on the PIP. Increase the PWA. But in a mechanomasturbation case, you have to go maximum up to 5 PWA because chances of pneumothorax is low. Then for the FiO2 saturation, you have to change the FiO2. That is the one important factor you are missing. So that has to be taken care. Third part. So even you are going up to the FiO2 of 60, 70, 80, and the baby still having retraction, better to change to other mode of ventilation like HFO until you are waiting for surfactant extra. Okay. And you identified the soft part very well. So you only ordered the blood pressure and CRP. Good job. Okay. The other person, what you learned from this scenario to tell, we should know, no? So we will ask one question, something like that. It's not exam based. So can you enumerate the 4 steps of dope? Tell the names. Okay. Sometimes what is that is to become. So that might be the reason. Then you just do the balance mass. That will help you. First to see for the displacement here. Sometimes it may come up here, here. Sometimes it may go here. Sometimes here it might go here. So these are all displacements. First you see for the displacement of the heel. That is very important. Then you go there and see 9 centimeters fixed, 9 centimeters. Okay. So you are sure it is not went deep inside. That is also displacement. It might go deep, might come out. These are 2 things you check. So here, 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 these are all the troublemakers. Okay, all you check. There is no displacement. Then immediately what you have to do? Obstruction. Open obstruction. For the obstruction part of how do you know whether the thing is obstructed or not? If you give air, the lung is moving, then there is no obstruction. So you will do the bagging and you connect this to the test lung. So other than this will not give alarm and you will be knowing that the equipment is working on that. So once you do the bagging, so you will see the obstruction is not there by 2 parameters. One chest stress, it is there, there is no obstruction. And by asked air increase, there is no obstruction. So the man said there is a different air intake both sides. That means there is a. That's the third step. What you have done for the obstruction? Suction. Suction. Suction has to be done by the 2 persons. So once you are going inside, you have just go for 15 seconds only. You should not do for much time. It will block the ET and the baby might have the desaturation too much. So that has to be done meticulously. So that is an obstruction. Third point is fever, pneumothorax. If the pressure might be very high and that it break the lungs. So to know the pneumothorax, we have a simple test. What is the test? Sound rocking. The translation. This light has to be very cheaper. It is there in every hospital. You just switch on all the lights, switch off the light and see. So this is the light illuminating up to here. This side the light is illuminating up to here. So there is a leak here. But this side is it's not coming. So there is a air leak outside the lung. So the air came from the lung break. So you have to put a needle here and you have to remove the needle. So that is the one step you have to do for P. P for pneumothorax. Then E for equipment. Equipment failure means this machine is working up. That one. So in that you have to change the settings and you have to optimize the pressures and all that. You have to see. Okay. So what are the DOP? DOP means D for displacement. O for obstruction. Obstruction of water. Tube. E for pneumothorax. Pneumothorax. E for equipment. Very. This dope you have to perform in your hospital breeding. Whenever the baby gets first, you have to do the dope. Okay. We already have. Ma'am, you want to ask one question to her? Specific question. Or you ask her to perform the suction process and we can rectify that. Oxa suction share. Just take the hand wash and oil. So for the suction, 2% should be there. Okay. So one person will do the bag and mask, other person will do the suction. There is no need to do the bag and mask mandatory. You can keep the baby on ventilator also. Ventilator and cannot reconnect back. Okay. Make suction. So then you check the pressure there. How much pressure you want? 100. So then depth of insertion. So what do you know that? It is there now. Measurement, you can use this scale. Also, there is a scale here. You can able to see the scale in the inside. Just keep it now. Yeah, you can just put here like this from where the numbers are starting. That also you can from example here. It is starting from here. So the depth of insertion should be mentioned on the here, or it can be mentioned here. Okay, where is the suction tube? So with the sterile gloves, you can just keep like this. And the rough idea of like rough idea without touching anything. You can use the available resource here. Yes. So you have to insert 9 centimeters, something like this. Okay. This is the depth of insertion. So you have to handle from here only. Okay. And once you remove this, so that has to be. So then you have to insert up to here only. Then with this rotating movement, you come back. This has to be done for 15 seconds, not more than that. That's it. If you deeply insert, that is a problematic. Second, if you put some NS and all the stuff, that is also not recommended. So this is the how. The depth of insertion is very important. What will happen? The baby trachea will damage over a period of time. The baby might get this subglottic stenosis. Extubation failures are quite common if you do deep, and VAP chance also very high. Okay, this is how you will do the suction. Very good. Anything you want to ask? Yeah. So how do you determine the pressure? How much the baby requires? So the baby is on ventilator, no? Whether the chest rise is good or not? Tell me. How do you see for the chest rise? You have to see from here like this. The ground level, the chest level, you have to. The eyes should be at the chest level and see. The chest rise is there now? Not there much. So if the chest rise is not there, you can increase the pressures. Okay? And see and tell you. 2 points you have to increase just for the sake of time. I'm just increase fast. So now the pressure chest rise is there. So this is how you have to see whether the ventilator is working or not. You will be knowing by the chest rise. If the chest rise is not there, the ventilator is not working properly. The baby is not getting properly whatever you wanted to give. Okay, this is how you have to see for the chest rise. Okay. Then if the baby having retractions, deep retraction, the tube might be blocked or the pressures PWP is less. This PWP that you can go up, but with the supervision and the team discussion, how much you want to go up. Okay. Anything you want to, ma'am?
Can you explain once again the
Just tell the names.
D is for displacement and O is for obstruction and P is for pneumothorax and E is for equipment failure.
Always remember this dope has to be done number of times. Every day you can, for the same baby, you have to do 10 times also. Whenever the baby desaturates, to do the dope. That's it.
Yeah, it was check for how much minimum you need.
Yeah, in the mechanoaspiration syndrome, the settings are different from the general, but as a rule, MAP, the conventional pressure of MAP, how much is it on that +2 for a heterogeneous lung or low lung volume. If the baby having pneumothorax, that is the reason for HFO, then you have to keep -2. So now the conventional mode of ventilation, how much is the MAP here? We'll show something. MAP is 7.3. If the baby is having pneumothorax, then you have to keep 5 MAP. That is not actually most of the time. By the time you put the HFO, the MAP will be 10. So 8 will be the MAP at that time. If the baby having RDS like picture as mechanoaspiration something, then you can go to 12. So delta P will be double the MAP, but the wiggling should be seen up to here. So up to the lower abdomen, you have to see the wiggle. Then based on that, you have to increase the FiO2 to whatever the baby requires. Okay. Always consider the pain. Pain has to be always looked for all the babies. Okay.
we can go that into
For the time being. So, but you should know what is the cause of that. For example, you said already sildenafil INO, those type of things you will start off. Better to keep the FAO to low only, but maintain the saturation. It's not like you should not keep 100% because the free radical injury will be there if you're oversaturating. Okay? Time up. Thank you.
You guys please introduce yourself so that we get familiar with your and see you soon. Okay, now that we've introduced each of us, so you guys form a team, at least 5 to 6 in a team. You guys allocate a team leader, take a role of a team leader, assign your responsibilities and roles, and come forward with the team. You have a time of like 30 seconds to 1 minute. You take this and come forward.
Those people who have already part on the role in the earlier scenario, those who have not done a single scenario, please involve yourself. So this is a we want this to be as close as real life situation. So, but it's a control environment, it's management, but you, whatever you want, if you apply, if you start a monitor, you want to put a pulse oximeter probe or ECG leads, it will be displayed on the monitor. Monitor will be here. You want to have any medications, any equipment, Dr. Our sister is here. She will help you out. She'll get you all the things which you need. You may not open the things which are there. You can simply assume that it is now, let's say, Ivilene, it is inside, and whatever medications you want. There are syringe pumps, there are monitors, there are all the equipments of airway, circulation, everything. Whatever you need, you can simply ask. Okay, when you are asked, when you have asked something, it will be provided. Till the time you don't ask for it, you won't get that information. So that's how we want to, go ahead. So we have kept a counseling room for the mother outside, so that a chair which is there, that's the counseling room. So we can counsel the mother or parents there. So you just assign among yourself one team leader, one senior doctor, junior doctor, and a couple of nurses, and other people can be observers. So at the end of the scenario, we'll take everybody's inputs. Okay. You will just regroup yourself and decide amongst yourself who are going to.
Is there anyone in the group who didn't participate in the 2 scenarios before?
They have not participated.
Please raise your hand.
They have not participated yet.
The rest all participate.
And whoever has done team leader in the previous two scenarios, select. So that all the roles will be done with me. You have 30 seconds to team up and allocate your roles.
So, for you take Bhavani, who is conducting the scenario, will also be the mother. Then he will magically transform into the conductor of the scenario. Okay. Have you decided who is going to be what? You have to. I mean, this is a World Cup going on. You can make a huddle, quickly decide who are going to be the team leader, who is going to be the doctor. Junior doctor, senior doctor, junior doctor. Junior. Two junior doctors, one senior doctor, one junior doctor can be you can senior doctor, junior doctor, two nurses. Two nurses. Okay. Please come forward. The rest of you can step back. One can be a senior consultant who will be coming into the picture, who is in a meeting, upstairs in the administration room. So if he's available on phone, so you can take his advice also. Okay. So this and has been very for the last 8 hours, 10 hours. And they have, because they are already busy into trauma patients and they are not at all comfortable with the neonate, they have straight away sent the lady after the neonatal. Let's please come here. Whoever I taken part. So so that you can participate. Assist. So now with this information, baby is expecting the baby to come at 10 point. When the baby comes, then you have to start whatever you want to do. Okay. I want you to be relaxed. Just do the things which you are doing on a day-to-day basis. It is not something new. We just have to ensure that whatever you are doing, you are actually communicating with each other properly and doing it properly. Go ahead.
Doctor, my baby is having continuous abnormal movements like this. My baby did not take things in the morning. My baby by 10 minutes help. Sister, take the that's my
ARDS is 36 milligram per deciliter.
Doctor, what is happening to my baby? Can anybody tell? Is my baby going to live? No, but it's all the sample blood collection, CBP, CRP, statistics, calculation. Just one of the step of the can you please stay outside? I will stay outside, but what is happening to me? First thing, let's get okay. Get intubation tray ready. Correct. 3.5. Hammer back. How much in you want? 5 million. Yeah. It's not ready for intervention or is it 30%. Carry was not. You were looking at it.
The film got between is over, it's 20 minutes long, one
Emergency post. What is happening to my baby? Can anybody tell me what is happening to my baby? Actually, one of you go and explain the mother that the baby needs incubation. Mother is talking. One of the children.
Is slightly decreasing in the left side. Now you will. You have one more staff who can do whatever other things you want to do. Just as it is there.
Connect the baby to the ventilator.
So PPA is showing. The CO2 is 35, CO2 is 56, and bicarbonate is 18, and ionic calcium is 0.85 millimoles per liter.
Over 30 minutes. Take the minute. No, medical content. That is 60 hours. Local show. 1/5 countries. Initially 20%. No, no.
So Priyata sister has called the senior consultant who is on phone. Somebody wants to speak in.
Senior consultant. Understand? Baby involved.
He wants somebody to brief him about it. Who is going to talk to him?
Senior consultant.
Hello.
Sir, baby serious control అవ్వలేదు సార్ ఇంకా సార్
The rest is
ఎమర్జెన్సీ సార్
it is arrived in the NICU. Did you check the recheck sugar? What is 75? Calcium
one dose of calcium 0.8. Status.
still focusing.
Loading of
He's can see that the child was intubated in minimal settings. So we'll start with infusion of minimal dose. To prepare that, I'm going to make the film. Okay, so let's use for here. I want all of you to read. I want all of you to tell us how did it feel? How did you feel? It was each one of you. So what will take the input from those who have actually participated? Yeah. Okay. So those who have taken the part, I want all of them to first describe in one word. How did you feel? First, how did you feel? Last time we had that like
So 1, 2, 3, 4, 5 are in the scenario. Yes. These 4 of them are not in the scenario. So I have a great point here.
how did you
Here.
Here, oh, you been saying. What are the good things you think you and your team did? One good thing. What are the good things which
You did.
So any child who is having neonatal or the time who is coming in emergency, especially seizures, so you have to check the just and to plan on immediately got the baby, monitor, and the next thing you want here. Then you got the information quickly, and that's why you have to good. Good point.
But you gave me you check the vital character. Okay. And you?
Exactly. Again, stick side. Take care of the agency first.
It's very good. Yeah, you know. So that will become information. So we'll start how good you shall we ask inputs from the other. So you can tell one or 2 points each quickly.
Good things.
First, which was done appropriately. controls were assigned. They were quick. Prompt and action. They first control the series and then process the next step of action.
So they were anticipating things and they started working.
Good point.
It followed the structure of
So starting from you, you can tell how differently we could have done, so that it would have been better. There obviously will be some corrections, right? Every time we do, it won't be 100% perfect. So what would everyone or anyone in the team have done in a different way, so that things would have been better.
So you start personally saying, okay, I feel I could have done this differently next time if like no process. So we start from you. Okay. That's it.
As soon as they become sleepy, we could have something like that. Okay.
Yes, it's important to have.
Technically, lifeline is important. Yes.
Yes.
Correct.
You can be very frank. Once we start realizing what we want to improve upon, that's how we are going to get better. So for every one of us, we keep doing mistakes. After 20 years, also we are doing mistakes and we are learning from it. As long as we are open to learn from our previous mistakes, the next patient gets better.
So just tell one aspect that it would have been it could have done in a different, would have been different.
For it and
You want me to give some country?
we can go to next.
Okay, you tell.
Yeah.
Usually, emergency situation coming. Help us. And we will start lending one class and we will take it first
Most of these were done. What you want to do differently? If you take care is what are the not done or you want to do it differently.
First step, we are just
Yeah. Yes. So there is also a promptly right. I want you to focus on how who are going to do that. Who is in something. Even patient which you want to change or which you want to do it differently. So think I improve care.
You also need time.
Go.
Yeah, you both can tell. You got some time. Yes, very valid point. Actually, what happened here was five of you were so engrossed in the scenario that the person who is not a part of a team member had actually come to me to talk about the day. I couldn't say no because I don't know. I'm a mother. I have to just talk to and yeah, about the counseling part. How was it done? Keep it aside.
One word about morning.
The section was good and knowledge has been improved as well as in theory, in skill. So we will implement in our hospitals now.
Thank you so much for saying you're going to implement in your hospital. Give her a big hand. Okay. What are your thoughts?
I think we have an excellent faculty. We are blessed to learn from you. And the sessions are all good. And the highlight is that you have let us to ventilate our feelings after, before or after every sessions. So session by session, we are evolving. And thank you so much for the opportunity.
Awesome. Thank you for being a great participant. So what are your thoughts?
It was like real life situations, what we really face in the everyday and throughout life. And the things where we go wrong at that moment, we are able to rectify the things and we make sure that we don't do these things again.
Awesome. So you felt it was a real life and you're going to try and implement wherever you go.
Good morning, ma'am. Initially, I was so tense, but early identification and appropriate interventions we learned here. You faculty taught well.
So you learn from the faculty, and so what is differently you're going to do after this?
How? That's what, madam. Early identification. How, when we receive the child, what are the appropriate measures we have to take? I learn.
Identification early and act. Thank you so much. Yeah, you can pass on the mic to your right.
It was really a very interactive session. And the key to managing any critical cases, better communication and giving our opinions, putting forward our opinions. It's a teamwork actually.
So mainly the teamwork
Yes.
you felt was great and the communication within the team. Thank you so much.
Great platform to make mistakes and rectify ourselves so that we don't commit such mistakes with our babies.
Absolutely. So mannequins can come alive, not the real patients. So thank you so much to say that we created a safe place to make the errors and learn from it. Thank you.
First of all, I would like to thank all the doctors who came from so far and help us learning the skills, ma'am. Take home message, teamwork, involvement, anticipation, and then that's it, ma'am.
Give him a big hand for saying anticipation. So that is a key, anticipate and plan. Thank you so much.
Good afternoon, ma'am. What I have learned is when we are assigned to a work, we have to be assigned to that work, not jumping from one work to other work. That I have learned in this teamwork.
Role allocation, right? If you're flying, what if the pilot says, I want to do the stewardess role, stewardess, you come and fly the flight. Doesn't work, right? So thank you so much. Wonderful. So give a big hand for saying the role assignment is crucial in crisis. Thank you.
What I've learned today is timely acting of things and be confident in what you're doing.
Absolutely. So confidence and competence, they should go together in managing the patient. If you're just confident, it's not enough, you should be competent. If you're competent, it's not enough, you should be confident as well. So thank you for bringing it up.
చాలా యూస్ఫుల్ వర్క్ షాప్ ఇది తెలియని విషయాలు కూడా చాలా నేర్చుకున్నాను థ్యాంక్ యూ
Excellent. Give them a big hand. It's the first time in the neonatal nurses and doctors coming together. And then hats off to you all. You're speaking up, you're interacting. So very proud of each one of you, the nurses in this workshop.
gaining knowledge, ma'am, and how to give proper treatment.
How to?
Give proper, like step by step.
Step by step, you learned how to manage a sick child. Thank you.
చాలా బాగుంది వర్క్ షాపింగ్ చిన్న చిన్న స్మాల్
Yeah, you
మిస్టేక్స్
can talk in any language. We'll interpret.
స్మాల్ మిస్టేక్స్ ఇలా ఎమర్జెన్సీ టైంలో తెలుసుకుంటాం ఎక్స్పీరియన్స్.
Awesome. So learning by mistakes, not just our mistakes, everybody's. That is the beauty of the simulation. Thank you for highlighting.
In emergency condition also, how to maintain aseptic technician, we learn so many things.
So everybody stand up and give her a big hand for saying aseptic precaution. Doesn't matter if you cannot intubate, put a line, but if you take asepsis, half the battle is won. Thank you so much for picking that up.
It's a good update for us, ma'am. We learn teamwork, communication, and where we can make mistakes and how to rectify it.
Absolutely. Excellent. Thank you so much.
It was really like meeting a real life incident. So it is not like not only restricted to theory. So we got hands-on on the practical, and from the approach onwards, like how not to panic. From that onwards, from the emotional level to how to manage a case, it was done.
Excellent. So the hands-on experience, not just the theory. And we wanted to go back and do the same. We did not use any high technology 3 or 30 crore mannequin. The simple mannequins, we can go and do it when we go back. Let me know when to stop. Yeah, okay. Yeah, let's hear from a couple and we'll continue in the afternoon. Yeah.
Firstly, thanks for everyone, and all the scenarios were live. It was real scenarios, and we were interacting, and it was improving our communication skills, and the teamwork. And what are the mistakes we do in our
Communication, teamwork, we hear the buzzword again and again. Was it there in the morning when you came, your expectation? All right, thank you so much. We'll hear from you, rest we can talk in the afternoon. Yeah.
Thank you, KIMS Cuddles, for this wonderful opportunity. Today we are I have learned how to work in a team and allocation of the work individually, so that every part is covered at a time.
Again, the buzzword is teamwork and role allocation. Thank you. So give a big hand, all of you, to yourself. You made this happen. So over to Aparna, the backbone of this workshop.
Thank you, ma'am. We are very glad that most of you felt that the situations were real. I think that's very heartening. Before we begin the formal inauguration program, just a word of thanks to, because everyone is there around. We've planned to formally thank everyone in the evening, but I thought, it would probably fall in the flow to actually thank the people who have actually helped us to put these scenarios all together. Starting from my team, Dr. Aravinda and Dr. Gautami, they've taken tremendous efforts over a period of few days, planning every step, of course, in close coordination with Dr. Gitanjali ma'am, taking a lot of inputs from her in planning the scenarios. Dr. Sindhu and Dr. Bhavani have helped us with a lot of disposables from Gachibowli, helping us with the supplies. And same with Dr. Praveen, including a mannequin which we borrowed from outside. We would like to thank Dr. Chetan for, again, his help. He's sent his team for participation, and he has also provided us a couple of mannequins from the Secunderabad branch. Thank you, Dr. Chetan. Dr. Bhavani ma'am and the other faculty members, Sindhu, Bhavani, Praveen, Dr. Gitanjali, all of you for taking out your time for rehearsing for the workstations. So all the faculty actually met a day before the actual workshop today. It takes a lot of effort to actually take out time from their busy schedules to actually do that. And I think that was why most of the scenarios felt real for the delegates. So we are very, very grateful that everyone took out their time and actually came out for a rehearsal. I don't think that's ever happened in any of the other workshops that we have ever done. Possibly it's not that important for a ventilation workshop or for an NIV workshop. You just need the things, but I think considering that simulation is so much about doing things the way we would do in reality, it needed a lot of rehearsing, and I'm sure you'll be seeing some of the reality and acting also in the afternoon. So I'll not break the suspense now. And from the hospital, I think I would be failing in my duty if I don't thank some of our pillars. Dr. Rohini is here, and she and her team, Shrikant, Monica, Vinusha, so they've all been helping, coordinating things. I mean, we have been making them run around for getting this and that, talking to the other branches, getting ambulances, getting incubators, whatnot. And we've been thoroughly putting them to a lot of trouble, I think, in the last few days. And they've been very, very enthusiastic and, putting their maximum energy to it. The marketing team, Mr. Dilip, Kiran, Kamal, Vasu, again, they've been kind of keeping time and, helping you all with the registrations. Thank you so much, all of you. Janvi, the IT team, Nagender is here. Thanks, Nagender and your team. Madhu, Bharat, right. So they've been helping us with a lot of things, including the Wi-Fi. We got a couple of tabs from the hospital too. All the faculty have taken efforts to download various apps, which you would have all seen in the scenarios for, mimicking real-time monitoring. So these required, again, a lot of syncing and rehearsals. The biomedical team, are they here? I think they're all kind of exhausted. I think they're arranging the ambulance for the evening session. So we have Mohan, Revant, Madhu, and Prakash. So again, all of them have put together all the equipments that you had all seen in the workshop. I mean, did I miss anybody else? Of course, KIMS, the whole team of KIMS. I'm sure the budget of the program was something that we didn't anticipate earlier. So they have been kind enough to absorb all that for the interest of keeping the academic flavor and the scientific content of today's session. So many thanks to the management, Dr. Abhinay Bolineni, Dr. Sudhir, Dr. Sudhakar, Bernard, and everyone from the management who has been assisting us. The F&B team for the lunch, which is, I think, the next thing to go. So now, I think I'll hand over to Dr. Surender. Dr. Surender is Secretary of Telangana State NNF. I think he doesn't need any introduction. He's been holding this post for a daunting 2 years now and is waiting to hand over. And again, it's been a very busy time for him organizing all the workshops and the conference. He's consultant neonatologist at Rainbow Vikrampuri. Thank you, Dr. Surender. And Dr. Vijayanand, again, he needs no introduction. A simulation expert and teacher himself. He's a workshop coordinator, committee coordinator this year. And he's been kind enough to arrange another intubatable mannequin through Ladle. Thank you, Dr. Vijayan and Dr. Surender. Over to you.
Thanks, Aparna. First of all, big round of applause for all of you for participating in this workshop. So you must be attending so many workshops, but when it comes to simulation, this time we thought, I think this is the first time transport simulation we thought of. Never previously we had this simulation transport workshop. So then I approached Aparna. She agreed to do this. I thank KIMS Hospital and a team of Aparna and her team for doing this wonderful job. And also, I'll be failing if I don't thank or acknowledge Madam who is here. She's expert and excellent when it comes to teaching with simulation, with respect to simulation. And Vijayanand is also associated with Madam Gitanjali Madam since a long time. And secondly, ventilation simulation would be there, other sepsis simulation or infection control. There are so many simulations. Now, when it comes to transport, it is always an emergency thing. So that is the reason we thought we focus more on as a simulation thing, how fast we can initiate transports. And of course, when compared to Western world, there are air transports, and of late, even in our country, air transports have started. But road transports itself, there is little laxity. So we all need to know the importance of emergency and getting these babies treated at where their care is needed for them, so that the outcome is going to be better. I'm sure you all will learn here everything related to transport very much, and you go home with a good take-home message. And most importantly, whatever we learn, if we don't put into practice, it's of no use. So learning is an everyday job. So after 16, 17 years of neonatology, we still keep learning every day. So I expect you all also to learn at the same time, put into practice, and thereby it helps us to save more and more newborn babies. So without wasting much time, I would like to thank each and everyone on behalf of Telangana State National Neonatology Forum. And one more thing is, we have our scientific session, which will be beginning from today evening 5 p.m. Delegates who have registered for the scientific program, they will be receiving all the nurses also. If you have registered for the conference, please do come there and attend the scientific program. There is a very good content of scientific program today and tomorrow. So 5 o'clock it begins, and we have gold medal paper presentations. Tomorrow there is a poster walk, and at the end of the scientific session, we have a quiz, an enough quiz tomorrow evening. So you will have knowledge in abundance. Don't miss. You will be only getting your respective certificates if you attend the conference there, scientific program. Okay, so I thank one and all. Okay. Do I need? Okay. Okay. Good afternoon, everybody. I'm Vijayanand, neonatologist from Rainbow Children's Hospital. And thank you, KIMS Cuddles, and the entire team, Dr. Aparna, Dr. Geetanjali, my guru in simulation, and entire faculty for doing this workshop. And this is probably one of the most important workshop. You might be saying same to everywhere. So I have a question for you. If you've gone to a NICU and or if you are asked to do a transport, you never been to, how do you feel? Happy, unhappy, comfortable, uncomfortable? You're asked to go on a transport, it happened to me in UK. I was put into transport, you go. You will be fine, you go. How do you feel? Feel good? Feel uncomfortable? Yeah, when you know, when we don't know what to do, obviously we feel uncomfortable. Okay? So that's where we need to make that comfortable. So that happens through the learning. When you turn your uncomfortable zone to a learning zone, then you grow. So then you enter the growing zone. And this is what the simulation-based education strongly believes in. Knowing is not enough. So having knowledge is not enough. Understanding the knowledge is important. Implementing the knowledge is important. And the translating that knowledge to the real patient care is important to get the right outcomes. That's what the simulation-based methodology believes in. And so that's why this workshop is very important. And thank you for the entire team to do this. I'm sure you, as I could hear from you, you learned quite a bit, but the learning continues. The purpose of learning serves, as Dr. Surinder said, when you go back to a place where you are working and apply them. Transport does not necessarily mean outside the hospital. Transport does happen within the hospital, within the unit, from one room to other room, from your radiology department. All these principles to some extent are applicable. So, and also of course, emergencies. I know we are waiting for lunch. I'm not going to continue further. I'll stop it there. Wish you very happy learning. Thank you.
I'll now request all the faculty who can just probably rise up from their chairs, leave your chairs as it is, and you can join us for the lamp lighting. Dr. Surendra and Dr. Vijay. Following which they'll distribute the mementos for the faculty and we'll then break for lunch. We can distribute. Okay. Dr. Sudhakar.
We have with EB fixed 9 centimeters. When ventilator parameters are 17, it fixed 840. The idle was net 40. Range is examination, ladies 40 and FI to 9 days. Pulse rate rate 168 BP 50 by 32, mark of 41 all through the transport. CRT is close to 3. Color wise, 3. Average Spanish square, normal, no movement. River push down 1.5 centimeters. Moving up to 1.3 ml per kg. 1.3 ml per sedated and fentanyl infusion with 0.4 mics per kg per and EBG wise, the EBG was having the metabolic acidosis, given 2 boluses and started on 9 drops with adrenaline infusion of 0.4 micrograms per kg per minute. Airway wise, intubator, ventilator, axis, we have a peripheral line and a central line placed on little venous catheter. The urinary catheter is in place. Digitory is present. That's the maintenance of OPNS with the 11 ml. Boluses, 2 boluses were given. Yes. 11. Annotates, ideas, they are tools.
That public or like the baby stable. That's it. So how did it feel? I think how the prayer baby
Present. Present exam.
How was it for you? So can you start? Yes, no. Okay, now what do we have to do? We put the rest over. Is it the paper? What is the next step? What do we need to do? Okay, what we need to do? Okay, ABC, what else? One is a stabilization of the baby. What else? No, no, maybe. We check the ABC. Yeah. Yeah. Awesome. Awesome. Okay. What's next? What do you want to do? Follow. Okay, mother has come. She wants to know about the baby. Mother has come. Yeah, mother wants to know what's up. That is good. Yeah. Introduce yourself. Confirm that is and say that we are looking after them all the time. Don't worry, we will look after you. Let's stabilize and we have to do some ways. Once you stabilize, come back and talk to me. Look at some person, take the mother and explain to them the rules of it. So introduce yourself. Then after that, answer. Okay, start. Okay, let's tell who you are. Introduce yourself. What's your name? This is so important. This is how we prevent the stone throwing. Introduce yourself. Say who you are. Ask your mother's name. Say it must be really hard for you. But it's not for you. If you provide that positive, okay, maybe I should start coming. So introduce yourself and say, maybe the party of it. Okay, go on. Yeah. Excellent. So don't forget the family. Who else you will think? Father, okay? The senior person go. Excellent. Time of no? Yeah. So one more thing, what you learn? What did you learn? Are you participating?
No, ma'am. Live.
Okay, don't do live.
Okay.
Delete the whole video. You do not want any live performance.
Had to undergo cardiac surgery. Basic intensive management is over. Now the baby is recovering, maybe on minimal oxygen for weaning and establishing full feeds. Probably the baby is getting transferred back to the level 2 center. That is called reverse transport. So you have different types of transport. So the need for transport is especially high in India because we know that there are different centers at, catering to different levels of care. So for example, you may have a baby with TAPVC, which may not be possible at a level 2 center in a small city or a tier 2 city. So this baby will need to be shifted on the respiratory support, hemodynamic support, everything that the baby is getting to the tertiary care center where the surgery or the intensive, the tertiary care service is possible. So this is swift and safe transfer of premature babies or other sick babies from hospitals without specialists or without intensive care facilities or without super specialization facilities, where the neonatal intensive care may have to be continued during the transport of the baby. So still transport, especially in India, is at a very, very nascent stage. So these are the different types of transports we discussed. So one is from the community to the first referral unit or first level health facility. The second type of transport is from the first level health facility to a tertiary level health facility. So timely and optimal safe transport goes a long way in decreasing mortality as well as morbidities. So we all know different candidates or different indications for transport, starting from prematurity or term babies having respiratory distress due to surfactant deficiency or pneumonia, or babies with persistent pulmonary hypertension may require nitric oxide, which is available at the the higher center, infections, metabolic acidosis, congenital heart disease, surgical problems like tracheoesophageal fistula, or there could be severe hyperbilirubinemia requiring exchange, electrolyte disturbances. So these are all different needs for transporting newborn babies. And the 5 most common causes in India are identified to be preterm, sepsis, respiratory distress syndrome, asphyxia, and HIE, followed by neonates with surgical anomalies. So when we look at the essential components of transport, possibly the most important component is all of you. So they have the presence of a trained medical and nursing team. That is possibly the most indispensable component that determines the quality of transport. So which is the reason why, all these simulation workshops are so useful, because it trains us for any kind of emergency that we may handle pre, during, and post transport. The other components are organization. So one must have a dedicated mobile number for receiving the transport call, or there must be a single point of contact who will be coordinating or receiving the call from the referring hospital and then communicating or organizing the transport from the referral center. Well-equipped ground and air ambulance system that includes a fully equipped transport ambulance. If it's a air transport, then it includes a fully equipped air ambulance. Communication and dispatch capacities. So that includes various things. So it may include ongoing communication. So there has to be a transport phone that the doctor carries during the transport. There may be remote monitoring system where you could have a CCTV camera within the ambulance, which is constantly being monitored by the doctor who is at the center, tertiary center, which is going to receive the baby. And then there should be written operational guidelines for transport. There must be a written SOP about how we manage different conditions during transport, which includes the transport consent form and the pre-transport, during transport, post-transport stabilization form. And all this must be backed by an institutional enhancement by policy and financial support. So there are 2 types of transport teams. Now, one way is to have dedicated transport teams, which means there would be some neonatal transport teams which only carry out transports. They may not be attached to a certain hospital, but say there is a team of 5 to 6 doctors, 10 to 15 nurses who takes shifts, and their only kind of commitment would be they wouldn't do clinical work in a standing unit, but they only undertake transports. So this is one way of having a dedicated transport team, which has been very successfully field tested in some other countries. But due to various feasibility aspects, it doesn't really happen in our country, right? Ours is still, the transport is fairly driven by the relationship between the referring center and the tertiary center, right? So because it depends upon this relationship, having a freestanding transport system doesn't really work in India for logistic reasons. So most of us have a unit-based transport system. So every hospital has a team of doctors, nurses who both manage the NICU as well as attend to transports as and when the call arises. So a transport team in India, I'll skip the part on the left. So the transport team in India essentially comprises 4 main people when we talk about the team. The first is the physician, the doctor. Like in a neonatal transport, it would be, a postgraduate, a fellow, sometimes consultant goes, the baby is very small, very sick, right? Then we have a trained nurse, a paramedic staff, and the driver, or if it's air ambulance, the pilot. So these are the 4 essential team members involved in transport. And these are all the expected skills that the transport team is expected to have in terms of intubating, being able to secure advanced airway, optimizing ventilation during transport, being able to do CPR, deciding, optimizing the dose of inotropes, securing lines. So a difficult peripheral line, if needed an intraosseous line, sometimes a central line, if both of these become challenging. Being able to monitor the vital parameters, identifying what all to monitor, and optimizing monitoring during transport, identifying any misadventures, and taking appropriate actions. So these are different types of transport incubators. All of us have seen, we have used different types of transport incubators. So in India, often the challenges include either non-availability of infrastructure. Very often we hear about this in some centers, or even if they are available, they may not be in optimal functioning capacity. So we often see when we go to a SNCU or a unit which may not be doing transport very often, there may be a transport incubator, but it is not functioning. There is an incubator, it is functioning, but it doesn't have a temperature probe. So it's very, very appropriate that all these smaller teething issues are identified by the transport team and constant measures are taken to make sure that they are being rectified. So it's very useful to have a checklist. The checklist must include equipment that have to be prepared for transport. So like you all did the equipment check before you you went for the transport in your station 1. So these equipment include the thermal care related equipment, including the transport incubator and its accessories like the temperature probe, the inbuilt oxygen cylinder, the inbuilt battery backup, and then the source of gases. So either it is a mixture of air and oxygen, or the ambulance itself might be having its own inbuilt air oxygen gas source. The monitors, which must be ideally multi-para monitors, where you can monitor the ECG, saturation, and NIBP preferably. And we may have to have more advanced parameters based on the severity of illness in the baby. We may need to have point of care blood gas machines, glucometers for monitoring the gas exchange and the baby's blood glucose levels. In terms of airway, you have already seen what are all the equipment that you need to have. So I'll skip this part. And then, of course, you have the lines, PMO lines, infusions, and medications when it comes to optimization of circulation. And you have some miscellaneous requirements, including IV cut down pack, lot of tapes, adhesives for securing the lines, securing the endotracheal tube, possibly some sampling vials, etc. So these are all some common equipment that are included in a transport checklist. We may also have to use some modified equipment. For example, an embrace phase changing mattress may come in handy if we do not have a transport incubator. If we do not have both of these, then probably the safest way to transport, especially a premature low birth weight baby, may be while doing skin to skin contact during transport. So these are all some aspects of key elements that must be communicated between the transport from the referring team to the referral hospital. So this is often identified with the acronym ISBAR. So it is identification of the need for transport. I. S is the situation. So what is the underlying background of the situation? So this includes awareness of the appropriate and available transport modality and options. So do we have a fully equipped ambulance versus a semi-equipped ambulance? Do we have a fully equipped air ambulance if it's a air transport? Or would we have to do with a smaller ambulance? Probably it doesn't have incubator. It may not have a transport ventilator, which means we may have to be prepared for hand bagging the baby while doing transport, etc. So awareness of the situation and the kind of equipment available, the background, so appropriate receiving facilities and acceptance by the receiving provider. Assessment, review of the current medical illness. So what is the sickness severity that the baby is having? Is this a baby with a cardiac problem? Is the baby having hemodynamic instability? Is the baby requiring multiple inotropes? So what is the sickness severity or current medical issue? And determination of required transport services, including personnel. And finally, the dispatch of the transport team. So there are a few responsibilities of the referring doctor as well as the receiving doctor. Again, I'll skip this slide. I'm sure you have discussed this during your workstations. So core aspects of pre-transport stabilization and actual transport. There are numerous acronyms to identify the core aspects of pre-transport stabilization. So you can use any of them, which is simple and easy for you. TOPS or STOPS is something that is used very often. It stands for the sensorium, temperature, oxygenation, perfusion, and sugar. So these are all key elements that have to be assessed and stabilized even before we transport the baby. So for example, it is not wise to start transport when the baby is still hypothermic or still hypoglycemic or maybe hypotensive. So it is wise to actually optimize the hemodynamics, the perfusion, temperature, oxygenation before we start transporting the baby. So these are different modes of transport as we discussed. So based on the distance involved, one may optimize or select which is the best modality of transport. So finally, this is an algorithm that talks about how we go about. We start with the transport call for a newborn who needs transport to a higher center based on different indications that we discussed in the first slide. So organization includes receiving the call, having a single point of contact, organizing all the requirements, arranging the personnel or the medical and the nursing team, checking the vehicle, transport incubator, transport ventilator, all the other equipment supplies including the oxygen gas source, air source, and the multipara monitor, and all the supplies and drugs, including laryngoscopes, endotracheal tubes, and IV medications, communication from the referring team, and things that are to be communicated or arranged by the receiving team. And we discussed about the pre-transport stabilization. You can remember using any of the mnemonics, of which STOPS is by far one of the popular ones, and then ensuring ongoing care during transport. So you have seen during the third station how we need to be prepared for in-transport deterioration. And finally, this finishes with an organized way of handing over to the higher center and receiving the baby. So reverse transport is a concept of the baby who has finished tertiary level care or has been stabilized or has completed the tertiary or quaternary care of treatment being transported back to the referring center. And this may be for weaning minimal oxygen support or for converting gavach feeds to oral feeds. And this may be very effective in terms of logistic issues and for cost cutting also. So thank you so much. We were just kind of filling the time until all the groups came back. So we reached the end of the workshop, and thank you everyone for staying through the very exhausting, but I think very fruitful workshop. So without wasting much time, we are going to have certificates only for the nurses. All the doctors who have registered for the workshop are already registered for the conference as well. I'm sure you are all aware. So we will be giving the certificates at the conference, at the end of the conference, which will be day 2. I hope you will be able to attend the conference in person. If any of you have any difficulties, you can reach out to Mr. Narasimha, whose number is available on the Google form on which you had registered, or you can also email him. You must have received email communication from the PS Neocon. So for all the nurses who have attended the workshop and who are also registered for the conference, again, we'll request you to collect your certificates tomorrow. Are there nurses who registered only for the workshop? Can you all please raise your hands? Yeah, so for all the nurses who have registered only for the conference, our team will be distributing the certificates as you move out of the hall. Thank you very much. We shall be also passing on the booklets, which will have some of these scenarios that we discussed today. With the permission of the faculty, we have kind of put together some material, and I hope that it will be useful to you. So any closing remarks from the faculty members? Gitanjali ma'am.
Very good evening, dear all. So as we told in the sessions as well as in the morning also, so whatever you have, experienced today, just carry it back to your units, keep doing it again and again. So unless you keep practicing it, it just becomes an entertainment and if you don't practice. So it was just a day spent with a good environment, good ambience, but if you don't practice it. But if you practice, it will definitely help in improving the way the unit functions. It ultimately gets the outcomes for the babies. Okay, so with that, and I think the management by the host team is excellent. They had thought it through, and last 1 month, 1.5 months, the whole team of Dr. Aparna has been working really, really hard. So I'm very glad and I'm very thankful for having this opportunity. I'm an outsider in terms of NICU, so I am just because of the simulation thing, I have come here. I'm a pediatric intensivist basically. Thank you.
Thank you, Chetan. I just want to say that I'm an outsider as well, pediatric intensivist, not neonatologist. It's great to meet you all, and we learned loads from you, and so that we can define our next section. And yeah, as Chetan says, take the torch from us and pass it over. Then only we can try to improve the patient care, and tomorrow it may be one of our family members coming. And you've been all great, and thank you for your patience and active participation. Take care.
I think let us, I'll not waste any much more time. You have been really good. I think all good participants, active participation, right? I think enthusiastic. Really, really appreciate that. Yeah. Okay. Hope really you have learned, taken some points, as Dr. Geetanjali said. Yes, we have learned too. It is a mutual learning. Please, don't keep it to yourself. Please spread the word and then keep practicing. That is what you need. Okay. Thank you.
Good evening. Thank you, Aparna Madam, for giving us permission for 2 minutes. I am Dr. Kiran Kumar Totawar. Vice President of HRD, Healthcare Reform Doctors Association. Is Dr. Srinivas Gunnaji, is NIMS RDA President, DN Clinical Pharmacology from NIMS. We are contesting for upcoming TSMC elections. Because of HRD only, we got elections. We went up to Supreme Court. We fought for 4 long years to get elections. Our main agenda is to eradicate quackery, abolishment of quackery. As the TSMC, Telangana State Medical Council, is the only legal authority which can file cases against quacks. So, by knowing the power of TSMC, we filed around 1,200 complaints with the TSMC in the last 5 years, but no single FIR was booked against them. As per NMC Act, 1 year imprisonment is there, 5 lakh fine is there if TSMC file cases. We went to root cause. Why having so much of power? They didn't utilize the power because they are the nominated members, continued since 2006 without any elections. So we filed cases in High Court. We got order in favor of HRDA. Then government went to Supreme Court. We implemented in the Supreme Court SLP. We won the case there with the Supreme Court orders. Now we are getting elections. So there are 13 posts. So total 96 contestants are there. We from HRDA fielded 13 members, dedicated members from 4 from Hyderabad, 9 members from different districts. Please do vote for us. You will get postal ballot by registered post. Most of the doctors received around 25,000 ballot dispatches from the TSMC. When you receive, you will get postal ballot like this in alphabetical order. There will be names and serial number, registration number. You have to choose 13. One person can choose 13 members. After marking that, you have to resend it to the TSMC by registered post. We will distribute. Please support HRDA for a change, for reforms in healthcare sector. Thank you.
Thank you. We'll have a round of distribution of mementos for all the faculty. So I'll begin with Dr. Geetanjali ma'am, senior most simulation expert.